One pro I have for you who are going to do any version of the ethics protocol would be to follow up, at least initially, those patients yourselves postoperatively, because these are not routine PRK cases. Some of these cases will show signs of significant external disease. So delayed epithelialization, white necrotic epithelial edges on a small persistent epithelial defect, some even Salzmann-like nodules. You need to be very aggressive in taking those out, playing a little with your steroids, or tapering off your steroids for a few days, a week maybe, till the surface replenishes. I wanted to show you a picture. I don't know if I have it in my computer, of a patient I saw at Greg's office in New York on Monday. Because this picture says 1,000 words. This is a guy I did PRK on, nothing to do with keratoconus, back in March. And great gentleman, lives in New York. We did him in Athens because he has relatives there. And 3 months later, he had haze in one of his cornea. So I started him on dexamethasone, which is the most popular cortisone in Europe. We don't have prednisolone acetate. And his haze is going away, but I wanted to show, and he's using it in just one eye. So this is preservative-free dexamethasone in one eye, and I had the epithelial maps from Greg's device of the other eye. So on the other eye, the epithelium looks perfect. The eye that he's using twice a day dexamethasone, the epithelium is blue. So you have to see this picture and understand why, and I thank Jordan for underlining this in his talk. It's so important whenever you think of refractive surgery, especially custom treatments, you need to have epithelial maps that are with you. But this is really a testament on how sensitive the corneal epithelium is and how we cannot really get an end result of the vision and the clarity of this patient until the epithelium becomes naive, and how strong of an impact even a preservative-free steroid can have on the epithelial remodeling. All right, let me walk you through this. We should, yeah, I should move. Questions. Anybody here is treating keratoconus? Okay. You think you're gonna do the leap of doing it tomorrow to get a treatment? All right. That's a tough decision to make, and I don't want this to sound like an infomercial, but if you're timid of you doing a topography guided treatment, try at least to remove the epithelium on one of your next cross-linking cases with a laser. Because since the epithelium will have remodeled, it will be thinner at the peak of the cone. If you do a 50 micron PDK, essence, you're going to shave off a little bit of that cone edge. So in a way, this is going to work like a topography guided treatment. You'll see remarkable. My friend George Quinones from Crete, who's done a lot of work parallel to ours in cross-linking, has reported on this, doing just the PTK and cross-linking. You'd be amazed of how much of regularization you're going to have that way. And I think the key thing here, which most people who are against combining the two treatments don't understand, is that when you do both of them together, there's a very strong synergistic effect. So if you look at doing cross-linking alone, they usually flattens the cornea about 2 diopters of the best. If you look at doing that topography guided treatment that we saw, that very elegant treatment, that probably would have treated 2 to 3 diopters of corneal irregularity alone. When you combine the two, that's when you can get 10, sometimes 15 diopters of corneal normalization. So flattening the cornea area and steepening of the corresponding area that was that flattens through the gel effect of the occasion. So which one is last one? All right. So Greg Powell is the go-to person in New York City. we've co-managed so many patients in the past before FDA approval for topography guided and cross-linking in the US since what, 2004, I think, 2005. So I think Greg has probably the longest and broadest experience in combining the two. And it's very good that since the approval, he does a lot of these cases in Manhattan. So also thanks so much for allowing me to peek in once in a while and use the stuff there.
One thing to mention about the epithelium, use the laser would epithelium, I think the recovery is much quicker. The speed at which the epithelium heals versus, I mean, I don't know if you're using alcohol or it's to scrape, but compared to alcohol, it's like 2 days quicker. Yes. So I'm gonna skip a lot of this, went through it all. The treatments that we use, keratoconus, post-laser aplasia, decentered ablations, expansion of optical zones, asymmetric primary treatments, and irregular corneal for previous treatments. So those are the 5 types of patients that I've seen over the years and treated. And the data captures something learn about your own, just going through it. So I'll skip this part. The key to these treatments is to stress to the patients that therapeutic treatment is not a refractive treatment in the sense that we're not trying to correct the refractive error. That's not the goal. Even though you will correct the refractive error, your goal is not to neutralize the refractive error. Your goal is to attempt to normalize the shape of the cornea, with the result being you'll probably end up with a refractive error, maybe worse than where they started from. And also, you may need to do a second treatment. That's the other thing that's very important. So sometimes we incorporate the residual refractive error in the primary treatment, and sometimes we advise the patient that there's going to be a second treatment involved in order to neutralize the refractive error. Most of the time, I emphasize the 2-step process that you may need an enhancement. So approach this with, if you're going into this procedure, I tell the patient, go into it with the notion that you will need a second treatment. So the standard pre-op measurements, we always try to get best corrected vision with a spiral lens or RGP lens, document that. We talked about the different types of treatments and the different things that can be modified, the Q value, the ablation zone, optical zone. John mentioned that in the US, we can't use a 5mm optical zone. It's only a 6mm optical zone. This slide actually John gave me. And just spend a little bit of time managing patient expectations. I found that this to be very, very important in the patients that I've treated because they often will come in, having read about this or being told by other physicians saying you could have this treatment done. They come in thinking, number one, that they're going to not have to wear a contact lens anymore for a keratoconus patient. So you have to quickly disabuse them of that false notion. And the most common thing is, I don't have to wear glasses or contacts after this procedure. And so that is sort of the most common thing that patients come in with, thinking that this is what they're going to get. So in our informed consent, we mentioned that this is a therapeutic treatment devised to normalize the shape to improve the quality of vision. It's not intended to correct the patient's vision. I mentioned that it's off-label, very important. I mentioned there are risks, including worsening of uncorrected vision, very, very important. It's the first risk I mentioned. Worsening of best corrected vision, worsening of progression of keratoconus, post-laser aplasia, infection, scarring. Glare and halos may improve, remain the same, or worsen, may require an enhancement to further normalize your vision. So those are just things that I would stress when you're approaching these patients. And then finally, you will still need glasses, soft contact lenses, or specialty contact lenses. And I mentioned the three types to achieve your best corrected vision. That procedure can not be guaranteed. So that's what I include in my informed consent. I think it's really important in the US. And then we have the patient sign these various statements that they accept that it's not an FDA approved procedure and it's not vision correction, accept the risk vision get worse, and that the procedure is not guaranteed. When John talked about the two approaches in the US, of course, there's the Athens protocol that we use, and then there's also a staged approach where cross-link is done, and then 6 months later, TCAT is performed. And this has been published. So in the New York area, my sense is that many physicians think that this is the standard of care when they refer their patients in. So let's get to the case study. It's interesting. So first patient, keratoconic patient. This is your typical patient that comes in who has been trying to wear a scleral lens, and he's undergone multiple refittings without success, and he's become frustrated. We offer him topo PRK, attempt to improve his best corrected vision in spectacle or soft contact lens. And so this was his manifest refraction. This was his original pentacam, showing a significant amount of irregularity. Yeah, very similar to what was just presented. And it's just a larger slide. And of course, as mentioned previously, you're doing both a myopic ablation and a hyperopic ablation simultaneously when you're treating these patients. In 6 months post-op TCAT, you had a much more normalized pentacam, and his vision reflected it. He had minimal amount of cylinder and improvement in his best corrected vision, picked up a line. But the key thing here is that he wears a soft contact lens. He's extremely happy that he can get into a soft contact lens now and see better than he can see with scleral lenses driving.
I mean, if I can jump in here, one of the advantages of ray tracing compared to topography guided is that, and we reported on this in Journal of Cornea, is that ray tracing takes. Actually, let me simplify. They've used a keratoconic cornea that's invariably sleep inferiorly as a tilted cornea. So it treats most of this as tilt, which means it treats more on the hyperopic arc and less on the cornea. On the thin part of the cornea that's the apex of the cone. And that's really tissue saving. Plus, can you go a slide back, Greg? What has not changed in this case, look at the back side of the cornea. In the front, the anterior elevation map is fantastically better. But since you're treating the surface of the cornea, you can't do anything for the backside of the cornea. So you still have significant coma that if this eye can be imaged by ray tracing, it will be taken into account. So that's another inherent advantage. The disadvantages of ray tracing, and this is again an off-label use for the US and for outside the US of ray tracing, is that it's more tissue hungry. So you may not be able to tackle a lot of refractive error, and that in very irregular corneas, it may not be able to get consistent imaging.
We wanted to achieve the same outcome with his right eye, but with the topo, with the Vero device, we were unable to get adequate Vero images despite multiple attempts and different techniques that one can use to try and obtain a good image. So unfortunately, he was not able to have the topo started out. So the important thing here is that it can complement contact lens fitting. So again, stressing that we're not eliminating the need for contacts, but we will improve the ability to wear a contact lens or potentially without any contacts. And finally, you can't really perform the treatment unless you get a good image capture. So the second case is a post-LASIK aphasia patient who had LASIK in 2001, referred to our practice for aphasia many years later. He underwent cross-linking his left eye, but he was unable to be fit with a specialty lens comfortably. He did show a stable Kmax over the 2 years prior to his treatment. And his pre-op refractive error was +1 -5. That's correct, 2030. Here is his epicam. Significant. Well, so this is 2 months post-op TCAT. Refractive error turned out to be a -575, so he became significantly more nearsighted, but his best corrected vision improved dramatically. And there's pre-post difference.
But again, because a lot of patients come back and complain to that point, and you make a very good point here, Greg. The refraction may be less myopic beforehand, but that is because they're shifting their visual axis somewhere in here. So they can shift the centroid somewhere over here, but that's not normal vision. So at night, nobody can imagine that this eye is seeing well once this pupil dilates. You get all that ghosting and glare. So in essence, there was not myopia induced. It's the fact that you have normalized the cornea. You flattened the cornea a significant amount. This is what, 7 diopters? And you steepened this part of the cornea another 6, 7 diopters. So you've corrected about 13 diopters of cornea irregularity. The cornea here is flatter. The apex was 53 and now it's about 46. The reason the patient has become manifest subjectively more myopic is because now they're fitting into more of the refractive error. It's a lesser refractive error, but it's a more normal cornea. So there's no place here for them to move the centroid or the visual axis and see better. I mean, I know this is very difficult to understand and explain to a 20-year-old or 22-year-old, but even ophthalmologists have come back and said, this is very common in Greeks. Well, you went to Canalopoulos, you were plano, now you're -6. Go figure. But that's not the case. Here, this is a cornea that's definitely normalized. It's definitely less deep. So theoretically, it should be less myopic by definition. But it's the physics in an irregular cornea that do sometimes work against the uncorrected vision.
Do you offer, and like after this, because they had that shift, and you say, hey, let's do an ICL or anything like that?
Yeah. So in this particular case, he was very comfortable wearing actually the daily lens, and I believe he even undercorrected it so he could read his 52. So he was quite happy.
But an ICL is a brilliant idea, man. We've started using a lot of this. We've actually used ICLs, Jordan, in eyes that we've crossed way back. And in some rare cases, about 2% of the cases will be a progressive flat. So they may end up being like a +7 or +8. And in those cases, you can actually use an ICL because they're very deep chamber eyes. They're not the typical hyperopic eye. And we've treated some of those with a hyperopic ICL. ICL is a great idea once they're stabilized. And there's also a debate out there whether you should go directly to an ICL in a keratoconic eye that's highly myopic and then try and normalize it, or normalize it and then use an ICL. Obviously, I agree with normalizing first and addressing the ICL because this is long-term, more stable. I think we're going to have to cut it here because I have a flight to catch. But if you have conclusions that I don't know.
No, I have just a few more cases.
Okay. So, and I think our time is up. Of course, it's at 5, so we're past 5. So I want to thank you for making it. I want to thank Dr. Weindar for being here. Impromptu, he's not on the schedule, but we talked a lot the last few weeks. He was kind enough to share with us some cases, and he's starting to become one of the most experienced surgeons with this in the U.S. And of course, Greg and Ed for laying in today. Have a great rest of the meeting and safe travels. And again, if you want me, I can put that QR code back on there. If you want to join the forum, and you have an opinion. If you want us to focus on the forum, something of your interest, we'll be happy. One thing I didn't mention is I have a pool of about 1,000 cases that I have all the pre-ops, treatment, and post-ops. And we used to, prior to Corona, do a whole day course on this, and looking at these cases and having a treatment computer here and designing them with you. I don't know if there's future in this. Often didn't want to adapt this as part of the training program. They felt there was too much liability in doing so. And I understand that. But that material is there and it's available for you to take advantage of it if you like. So let me go back to those QR codes. And that's then here. So the left one, the greenish one, is the YouTube channel, and a lot of the techniques and the presentation for today will be on there. And the right one is the forum where you register and you become part of this custom treatment community. And come back with cases, questions. If you want us, we'll post these cases to the forum. We'll get opinion from different doctors. If you want this to stay, anonymized between me and you guys, I'll be happy to do that as well. Thanks so much for coming. And again, sorry to have to run out. But I think I have a good guy ready for